Good morning, good afternoon, and good evening, everyone. I'm today's session 6 moderate, Zhang. I'm a professor working in Beijing Institute of Technology and the vice director of Lancet Institute. And today we're gonna give you a session 6, Vector-borne and Zoonotic disease and climate change. First of all, I would like to introduce you the course objective. This course, we're gonna increase your health professionals' knowledge, self-efficacy, and communication skills related to climate change and health. Expand global workforce capacity to develop and implement educational program on climate change and health. Build and strengthen an agile and informed community around climate and health education, advocacy, and policy. Today, we're gonna have session 6, and we still have another 4 sessions to go. For the learning objective of today's session, today, our session will explain the environment process changing as a result of climate change and how they impact prevalence, incidence, and distribution of vector-borne and zoonotic disease. Explain modification in vector, reservoir, and pathogen life cycles for the following disease. Explore what action health professionals can take to identify and protect patients vulnerable to this disease. Define steps the health sector can take to become prepared to address shifting geographic burdens of vector-borne and zoonotic disease, including increasing surveillance and early warning system and broader interdisciplinary coordination. We will have a 90-minute session, include expert lectures and case study presentations. The session will be culminate with questions and answer sections. Please enter your question for the presenters in the Q&A chart. The whole session video recordings, slide decks, and resources will be made available on the course website. For the attendance rule, attendance is automatically recorded during this live Zoom session. Your individual attendance is only counted if you join using your own personal Zoom link, which cannot be counted if you join with other colleagues' link, and YouTube views cannot be counted towards attendance. For your certificates of participation, all the participants who attend over 70% of the live sessions and pass the final exam with a score over 70% at the end of this course will be awarded a certificate of participation in climate and health from the GCCHE. And the final exam. The exam must be complete using the same email address used to attend the Zoom session, and the exam link will be sent on the final day of the class via your email and WhatsApp and will close on Sunday. We will offer you 25 multiple choice and true and false questions. Participants who should be prepared to take the exam in one sitting. And then I would like to introduce the 3 renowned presenters of our session today. Professor Liu Qiyong, Professor Katie Anders, and Professor Tran. So the first presenter is Professor Liu Qiyong, who is the chief expert of vector controls in China CDC. Professor Liu is a leading expert and scientist for vector surveillance and control and leads national research on health and climate change in China. Professor Liu heads the WHO Collaboration Center for Vector Surveillance and Management and has been awarded over 20 national and international prestigious grants, including National Basic Research Program of China, Australia Agency for International Development, and the Wellcome Trust, for etc. Professor Liu has more than 35 years of experience in public health and research, who is a renowned influential public health leader for global significance through his important role and appointment in WHO Western Pacific Region Office. With expertise in zoology, ecology, epidemiology, microbiology, and immunology, Professor Liu has dedicated himself to public health research with a focus on the control of disease vectors and vector-borne disease and accessing climate change-related health risks and adaptation. So for the next 35 minutes, I'm going to pass the floor to Professor Liu for his presentation. Welcome, Professor Liu.
Thank you very much, Professor Zhang, for your introduction. I would like to share my slides. Okay, it's my great honor to share this talk, Vector-borne and Zoonotic diseases and climate change. This is the outline of my talk. First of all, we would like to know the global vector-borne disease and zoonotic disease. And the WHO has a short list for the vector-borne disease. You may find this for this here is the first column. It showed the vectors, and the first is the most important vector, and a mosquito. And for these, we have three groups. The first is the Aedes. They can transmit a lot of mosquito diseases. We are familiar with some of them: Dengue, Chikungunya, and the yellow fever, and the Zika virus disease. And they are very active and in the world. And for the anopheles, we know the malaria is the very severe burden of the global or regional level. And the Qiyong, we have several of them. So for example, Japanese encephalitis, and it's endemic in our region, and especially in China. So there are lots of these vector-borne disease. I would and I couldn't introduce one by one. I just have a look, and they are appeared in the world, and we can find this map. If from a Lyme disease, tick-borne encephalitis, and the plague, and also the other with blue. It means we have the new emerging problem, or they have the re-emerging problems, such as the red ones. And we know that dengue is the one of the most serious vector-borne disease nowadays. And there are three major trends in the prevalence of vector-borne disease in the world, driven by multi-dimensional factors such as climate, globalization, and also the ecological change. And the first is there are more and more new diseases constantly emerge, such as the tick-borne disease, and also the distribution of the known vector-borne disease and zoonotic disease. They are expanding to vertebral scales. For example, for some disease, traditionally they are tropical diseases, but now they are expanded to subtropical and temperate zones. And also for their epidemic seasons, they become longer, and they will cause much more serious public health problems. And the last is that the frequency of the epidemic scale continue to increase, such as dengue, Chikungunya disease, and also the Zika virus diseases. As for China, we also meet the challenges for vector-borne disease. You may find these slides, and we based on our national law of infectious disease prevention and control, we have 41 notifiable infectious disease. 10 of them are vector-borne and zoonotic diseases. You may find the plague and the other that is the class A, class B. We have 6 of them, and the class 3 C, we have 3 of them. And we also have 10 of the vector zoonotic disease is locally epidemic, or they may also cause the global global issues, such as the Zika virus disease. Except the 10 plus 10, we also have the lot of other neglected tropical disease and emerging infectious disease, or the unknown vector-borne and zoonotic diseases. Yeah, this number is become larger and larger, and now we have research on the infectious disease in China from 1950s until now. Based on our research, we found there are more and more infectious disease, and also the pathogens diversity becomes much greater, and you may find the different pathogen species, and also the different genomic types. And last we found there are 3 main causes for this issue: is ecology, climate, and human behavior changes. And the climate may have the impact on vector-borne diseases, and we all know recently we got the much greater challenge from the global warming in a recent decades, especially. And based on the climate change synthesis report, we can find some effects. And the climate change may cause the health risks, and through the different ways or all the pathways. And the first is the direct effects is mostly contributed by the extreme weather and the extreme climate events. And they can cause the human death or injury. And the climate change may impact on our environment and the vector, the host animals, and the pathogens. Then they will cause the vector and vector-borne and zoonotic disease epidemic patterns changes, and these is the indirect effects. And also they may impact our social, especially the public health, the measures or strategies, then they will cause the impact on our health, especially for vector and the zoonotic diseases. And we all know for vectors, the adapted to the climate and the climate different factors such as the temperature, precipitation, wind, and also the other factors. They may find the right place to suitable for them to live, and they also they may cause the problem of vector and zoonotic disease. These factors will be integrated in with the social factors. Then they will really change the patterns and the French of the vectors and the vector-borne diseases. In this slide show that for each of the vectors, you will find that they are suitable suitable niches, and for example, for cold and for heat and for flood, for the drought, they may also cause the impact. Then they may adapt to the change. And for this, we how to adapt to the extreme weather events. For example, vector-borne disease, we also have the similar issues. Let's share this example, how the climate change will impact vector-borne disease. I would like to select the dengue, and we all know dengue, they can transmit by mosquito. Yeah. And the Aedes mosquito, Aedes aegypti, and Aedes albopictus. For the mosquito, they have the 4 stages of their life cycle. You may find this the adult, and they can have the eggs in water. The eggs will then emerge to the larvae, and then the larvae will get to the pupae. The pupae will emerge to the adult. For the different stage of their life cycle, they may impact by the temperature and the precipitation. And if the mosquito bite the dengue infected patients, they can get the virus. The virus will circulate and in the mosquito, and after about 12 days, they may have the very good circulation, and then they come to the glands. They bite people. They can transmit it to the suspected the people. These people will also have the incubation period after 4 to 10 days. These people will become the dengue infected patients. Yeah. Then in the different stages, they also have the impact from the temperature, precipitation, and also the other factors. And we may find that if it really affects on this Then let's see how to do the research to assess their impact on the vector-borne disease. First of all, we try to identify the dengue hotspots, and based on the spatial temporal analysis. And based on that, we find this, and we screened all the factors to find the main determinant factors. Then we can establish the modeling, and based on that, their interaction, the modeling established. Based on that, we can project or predict their trends in short term or in long term. And we also can try to do research to assess our public health system, if they have the adaptive capacity, for example, for the CDCs, if they are ready for these changes, and then we can find the gaps. Then we can strengthen our capacity building program to promote our adaptive policy and action plans. Okay, we can see these slides. You can see the global warming really have impact on the first. It have on the impact on the EDs. This here is A. This they show the EDs. They are expanding on the pattern, and you will find that this is the EDs or pictures in the world. Also, we have the different roles. And for the EDs, it emerged from the West Africa. Then they will contribute to the different region of the world. And it is for the Egypti originally from Asia, but now it's expanding to the much more areas. It's going along with the global warming and also the global trade. As we have the different cycles for the vector-borne and zoonotic disease, this is the Sylvatic cycle and the rural cycle in the rural areas, most of them, and zones of emergence. Then you can come to the urban, to establish the urban cycle. There's the interactions between the different zones and regions. You may find this is the how to predict dengue outbreaks in Guangdong province, Yunnan province, to use in the climate data. And we try to establish the models and to establish the model for the risk assessment and early warning, and then to for a precise response for public health. And based on research, we really found the temperature and the precipitation. The first, they will provide the good niches for the mosquito, Aedes mosquito. You will emerge more and more to make the population become more stronger. And it means the vector capacity will be high, and they will reach or above the threshold of transmission and even the outbreak levels. And then they will cause the dengue incidence But there's also other routes, the pathways, they can also contribute to the maybe this for this routes, they have the different factors, and I think that the first of the most impacted or the determinants is social behavior. See, social behavior because of global warming, and it also really change our human behaviors. So then there are different factors we can find. There's some bio or the environments and the determinants, and then we can establish the modeling. Okay, we can see based on our research, we found this for the different scenarios, and the RCP 2.6, RCP 4.5, RCP 8.5, and you can find in future, for example, also 2021 to 2040. Yeah, these are different things. You can find this. There are more and more suitable zones with a higher risk of the dengue transmission, and in China, and you will find it's really a bigger challenge in future in different scenarios, different stages. And for the vector-borne prevention and control challenges, we found that now we try to understand how it's impacted and to find the ways how to intervene for better public health the outcomes. We all know this, the pandemic caused by the Zika virus disease. Yeah. And in 2016, WHO announced that this is fake. Yeah. And but this virus is found in 1947, but it's really weak. And even for the hundreds of the cases in history is rare, and only one of the cases in 2010 in Cambodia, they found there's more than 1,000 cases outbreak, but in 2016 it's really caused the global pandemic. And based on this, we try to establish the prevention and control and with the different diseases. We have prioritized the vector-borne diseases. For example, here is the malaria. We talk more about the dengue, except dengue. There's also we have the malaria, Lyme disease, leishmaniasis, and the Chikungunya disease. They may also cause the global pandemic because of the global warming and the urbanization, especially for Aedes-borne diseases, because the Aedes, such as the Aedes aegypti, Aedes albopictus, they are really good adapter to urban area too. And they will increase the incidence of vector-borne diseases. So WHO developed the Global Vector Control Response 2017 to 2030. There are all these based on the World Health Assembly. World Health Assembly is the 70th World Health Assembly. It becomes the Global Vector Control Response 2017 to 2030. It is the signal of the new era in vector-borne prevention and control. You may find this for this response, they have the goals and the milestones in different stage, and the final goals is the case fatality or the mortality from at least 30%, 50%, 70% by 2020, 25, and 2030 to decrease these by at least 25-fold. That means for each of the member states, we also need to fulfill this goal, and we really really need the prevention of the outbreaks and the epidemics of the vector-borne disease. For all the countries, we need to establish the capacity. So the last is to create a world free of the hazards of vector-borne disease, and to reduce the burden and threats of vector-borne disease through effective and sustainable vector control adapted to local conditions. So in 2004, we published the Sustainable Vector Management to respond to the global challenge of vector-borne and zoonotic disease, and also we try to promote the sustainable human resources, sustainable vector surveillance control technology, and sustainable administration, and sustainable finance support. Based on this strategy, we strengthen the 4 stages and the 2 factors. Vector surveillance and the risk assessment is the fundamental public health work. And based on that, we can develop the control planning and the preparedness. And based on the surveillance, we can initiate integrated vector control. And based on the surveillance, we can evaluate our control effectiveness. Then we can adjust our public health measures and strategies. I would like to share this the example in China. We established a 3-in-1 national vector surveillance networks and early warning on the vector-borne diseases. This is the ecological surveillance, and there's and also this the national surveillance sites. You can ask for resistance to the public health insecticides, and also the national surveillance for the pathogens of vector-borne and the vectors. For example, the mosquito and the tick and the rodents. Based on this, we try to make use of data for a precise vector control based on our program. to make it more efficient and precise control. Yeah, it is a platform we can have the real-time early warning, and also the decision making, the supportive to decision making. And we try to change the control model of vector-borne disease from a passive outbreak emergency control to active outbreak risk management based on a vector surveillance program. Then we can find that the threshold and the outbreak threshold, the transmission threshold, outbreak threshold, and the original epidemic threshold. Based on that, we can send out the signal for the local government and communities to take action for mosquito control program to decrease the vector populations and their vector capacities to minimize the outbreak risks. So for promoting this sustainable vector management, we established the biannual international forum since 2006, and last year we have the 10th of the international forum on sustainable vector management. Next year we have the 11th international forum on sustainable vector management in Shenzhen city. And you know, it's the southeast Guangdong province. As the WHO promote the One Health, I think this is really opportunity and also the strategy for us to make use of our resources and the multi-sector collaboration and interdisciplinary innovations for the sustainable, the precise control of vector-borne and zoonotic disease, One Health. So thank you very much for the opportunity to share my slides. I would like to communicate with all our participants. Thank you. Thank you very much.
Thank you, Professor Liu, for your informative and inspiring presentation. Thank you very much. So our next speaker is Professor Katie Anders. Professor Katie Anders is an associate professor and an HMRC research fellow in the Planetary Health Division of the School of Public Health and Preventive Medicine at Monash University, and a member of Monash Health and Climate Initiative. Her research interests are in the generation and dissemination of knowledge to support scale-up of effective strategies for controlling dengue and other vector-borne disease, and in the interaction between local and micro drivers of arboreal disease, epidemiology, and intervention effectiveness, with a focus on the Asia and the Pacific region. Let's welcome Professor Katie Anders.
Thank you very much, and I hope you can hear me clearly. Please let me know if there's any problems with the sound. I will continue for now. Thank you to the organisers for the opportunity to present in this wonderful course. I will be presenting this case study on an innovative method that's being used in many countries for controlling dengue and other arboviral diseases by release of Wolbachia-infected mosquitoes. So let's see. There we go. So this tool, this Wolbachia-based method for dengue control, is focused on controlling the diseases that are transmitted by this mosquito, which we've just heard in the lecture, is the Aedes aegypti mosquito, which is the primary vector for dengue, as well as other viruses, including Zika, Chikungunya, and yellow fever. And the case study that I'll be presenting, most of this work was done during the 10 years that I worked for the World Mosquito Program, which is a not-for-profit organisation, came out of a translational research program at Monash University, where I was the Director of Impact Assessment until December last year, when I moved into a different role at Monash University. So as we've heard from Professor Liu in the previous talk, dengue cases are really escalating rapidly worldwide, and this graph here it emphasizes that. This is the number of dengue cases notified each year up to last year, where we can see that the size, the frequency of outbreaks, and also the number of countries affected by dengue outbreaks has increased dramatically over the past 2 decades in particular. There were a record 6 million dengue cases notified in 2019 and again in 2023. And then in 2024, there was this unprecedented surge in dengue transmission globally, particularly in the Americas, but also in Asia and other areas, which saw more than 14 million dengue cases reported worldwide and more than 10,000 deaths. And many countries also had concurrent outbreaks of chikungunya and Zika last year as well. As we've heard, climate change and urbanisation are 2 major drivers of this expansion in dengue. And the map that I show here is adapted from a publication that modelled the projected further increase in dengue risk worldwide, where the orange areas are geographies where dengue risk is projected to expand by 2050, and the green, harder to see areas are where there may be a contraction, so reduction in dengue risk due to climate and urbanisation factors. And this model projected an additional 1.5 billion people to be at risk of dengue by 2050. The challenge is that we only recently have vaccines licensed for dengue. There was one by Sanofi, it's not widely used, and another by Takeda, which has been licensed in several countries over the past couple of years. But those vaccines are still being scaled up to reach population-wide coverage, and there's no specific therapeutics or antivirals for dengue and no chemoprophylaxis. So the major approach to controlling diseases transmitted by Aedes mosquitoes is vector control, as we've heard. And it's the preferences of the Aedes aegypti mosquito are what is both driving this surge in dengue, but also presenting challenges for control of disease when the focus is on reductions in mosquito populations, because Aedes aegypti prefers to bite only humans. It lives in and around domestic residences, inside houses, where these fogging, insecticide fogging activities that we see in the bottom pictures have a difficulty in reaching those places where the mosquitoes are resting inside homes. And also we're seeing an increase in insecticide resistance that further challenges the effectiveness of these interventions. The top right picture shows the application of larvicides to breeding sites. Again, issues of insecticide resistance create challenges, and it's very difficult to scale these insecticide-based interventions and also environmental management to reduce breeding sites throughout very large and complex cities where dengue causes a big public health burden. So, as well as vaccines, there's an urgent need to integrate other innovative approaches into dengue control programs. And that's what the World Mosquito Program does has been developing and implementing Wolbachia-based control of dengue and other Aedes-borne diseases for 20 years or more now, first in the lab and now in the field. And the Wolbachia method employed by the World Mosquito Program differs from these other approaches in that it's not trying to reduce the mosquito populations. Instead, it's transforming the mosquito populations so that they are resistant to arboviral infection. And it does this with this naturally occurring endosymbiotic, so living naturally inside the cells of insects is this Wolbachia bacterium. It occurs naturally in around half of all insect species, including moths, butterflies, lots of other mosquito species, including Culex and even Aedes albopictus, but it's not naturally found in Aedes aegypti mosquitoes. It's transmitted from the female insect to her offspring through the eggs, and because it's so prevalent in the environment, naturally we can be confident that it's safe for humans, animals, and the environment. It's not an introduction of a novel agent, and it cannot infect humans or other vertebrates. And so what the discovery was that led to the development of this as a public health tool was that Wolbachia could be isolated from either the fruit fly, Drosophila melanogaster, which is called the WML strain, which is what our World Mosquito Program mainly uses, or from other insect species, for example, Aedes albopictus, which is called the WLB strain of Wolbachia, and micro-injected that purified Wolbachia into eggs of Aedes aegypti, which are then reared up to adults and create a colony of Wolbachia containing Aedes aegypti mosquitoes, which is then perpetuated in the lab because each new generation inherits the Wolbachia through the eggs, and so you have this stable introduction of Wolbachia into Aedes aegypti mosquitoes. It doesn't change their feeding behaviour. It doesn't affect them. It theoretically can incur some fitness cost, but for the most part, it makes no change to the Aedes aegypti mosquito. But the discovery that really made this a public health tool was that when Aedes aegypti mosquitoes have Wolbachia in their cells, it inhibits the infection of Aedes aegypti with dengue and other viruses when they're fed on a viremic blood meal. And it also, if they do get an infection in their abdomen, it inhibits the replication and dissemination of the virus in the mosquito. So it significantly reduces the mosquito's ability to pass the virus on to the next person that they bite. And just to mention before I go on that there are two ways in which Wolbachia infected mosquito releases are used. The one I'll be talking about that's employed by the World Mosquito Program is this first virus blocking approach, which is also called population replacement, which is when male and female Wolbachia mosquitoes are released, and the intention is to replace the wild Aedes aegypti population with Wolbachia carrying mosquitoes. The one on the right involves only the release of male Aedes aegypti Wolbachia mosquitoes, and the action there is a population suppression. So a similar mode of action as insecticide-based or other mosquito control, but here it's the Wolbachia in the mosquitoes that causes, when they mate with a wild female, her eggs are sterile and will not hatch. So it's a sterile insect technique, and that's being used in China and Singapore and southern United States and several countries, but I'll be talking about the first, replacement or virus blocking approach. So the way this is operationalized as a public health method is that you have a city with a wild mosquito population of Aedes aegypti shown in dark blue here. you have releases of Wolbachia-infected Aedes aegypti that have been reared in the insectary and can be released either as eggs, so little capsules with about 300 mosquito eggs and some food, and are put in a bucket or a soda cup here with some water, and the mosquitoes are allowed to pupate and emerge and fly into the community. Or they can be reared to adults in the lab and released from little cups, or here on the bottom in a sort of tuk-tuk, through automatic release of a fixed number of adult mosquitoes as the vehicle drives along. And those Wolbachia-infected mosquitoes mate with the wild mosquito population and transmit Wolbachia to the next generations. And after a period of several months of releases, the releases stop, and Wolbachia continues to spread into the wild mosquito population and then self-sustains. That's the important part. This is a fixed period of releases without further intervention then required, because Wolbachia mosquitoes, shown in the light blue, self-sustain in the mosquito population going forward. And so World Mosquito Program is a not-for-profit, as I mentioned. It's wholly owned by Monash University, and the first releases of Wolbachia mosquitoes were done in northern Queensland in Australia in January 2011. And since then, World Mosquito Program and their partners worldwide have implemented this method in more than 30 cities in 14 countries worldwide, reaching more than 13 million people so far. So I'm going to show you some of the data from those releases here. But before I do, I just want to highlight that engagement with communities and governments and other stakeholders has been central to the way that World Mosquito Program has operated right since the first releases in Queensland. Obviously, this is a slightly counterintuitive intervention to be releasing mosquitoes to prevent a mosquito-borne disease. So there's a lot of one of the first activities in every new site is awareness raising and having community reference groups and community events, and making sure that that there's no opposition to this and it's understood why this is being done, and that communities and stakeholders want this intervention before a single mosquito is released. So I put some pictures here of the types of community engagement activities that are done in the various sites. So as I said, the first releases were done in northern Queensland in 2011, initially in two small suburbs, isolated suburbs outside of Cairns. And for those who might not be aware of the ecology of northern Queensland, there are Aedes aegypti mosquitoes just up in this very northern tip of Queensland, where it's shown with the red square there. And historically, there have been dengue outbreaks in northern Queensland, seeded by returned travellers coming back with a viremic dengue infection and having competent Aedes aegypti mosquitoes who can bite those returned travellers and start a local outbreak. What this graph shows here is that long-term monitoring of those release areas in Cairns and Townsville, where the releases were expanded to cover all of the previously dengue-prone areas of northern Queensland. What the blue line shows here is the monitoring where you catch back Aedes aegypti mosquitoes from the field and test them by PCR for the presence of Wolbachia. And this shows that the Wolbachia prevalence in the local Aedes aegypti mosquito population was sustained at very high levels, above 90%, until the most recent monitoring, which is now more than 10 years. And actually, there's new data that's not published yet, but now, I think more than 13 years, Queensland Health still does this monitoring and showing that Wolbachia is stable in the Aedes aegypti mosquito population. And I haven't shown data here, but this has really led to almost total elimination of local dengue outbreaks, with the exception of a few sporadic local cases, but not the large outbreaks that were seen previously. But this is not an endemic setting, so to demonstrate the efficacy of this method, we worked with colleagues at the University of Gadjah Mada in Yogyakarta, Indonesia, to conduct a cluster randomized trial several years ago now, 2018 to 2020, where we randomized 24 clusters, 24 areas of Yogyakarta, shown in the map here, to receive Wolbachia mosquito releases in blue, or to just continue with standard dengue control measures in white. And the clinics are shown on the red crosses there, where we enrolled patients presenting with acute febrile illness and tested them for dengue. And the results of this trial showed that there was a 77% reduction in dengue incidence in the Wolbachia treated areas, and an even larger reduction in hospitalised dengue cases, and efficacy was demonstrated against all 4 dengue virus serotypes. So this is the one cluster randomised trial that's so far been completed. Another is underway in Brazil that'll be finishing later this year. But in Yogyakarta and all of the other places on the map that I showed you previously, we also measure the impact of Wolbachia releases on dengue using routine disease surveillance data. What this first graph shows, though, is the Wolbachia. So the green line is again that prevalence of Wolbachia in the Aedes aegypti mosquito population over time, showing at the most recent monitoring. There's one since then, but in January 2023, more than 5 years after the first releases, Wolbachia was also still above 90% in the local Aedes aegypti population. And this bottom graph shows that notified dengue case incidence in Yogyakarta back to 2006. Monthly dengue incidence per 100,000 population, with frequent seasonal epidemics, as is typical for these endemic areas. And then when Wolbachia was rolled out, as shown in the shaded blue area, first across half the city for the trial, and then the whole city once the trial finished and we filled in the untreated areas, we've seen not a flatlining for various reasons. This is clinically suspected dengue. These don't have laboratory confirmation, but we're seeing this real interruption of those regular dengue outbreaks that were seen historically. So in the last few minutes, I just want to highlight a couple of the Pacific sites where we've worked, since that's the focus of this session. And we had Australian government funding, DFAT funding, to deploy Wolbachia in 3 Pacific Island countries in 2018-2019. So the data shown here is from Fiji, where deployments were done in Suva, Nadi and Lautoka. And these are very small graphs, but each of these are areas within Suva at the top, Nadi in the middle and Lautoka at the bottom, where the orange line here shows the Wolbachia prevalence over time, and the orange shaded area is when the releases were done. So there's some variability in how long it takes to go in or what level it eventually reaches. But in general, this showed successful establishment and persistence of Wolbachia in the Aedes population in Fiji. Similarly, in Port Vila in Vanuatu and in Tarawa in Kiribati, where the baseline Aedes aegypti population prior to releases was among the highest mosquito abundance in any of the sites that World Mosquito Program had worked, but still Wolbachia was able to establish there. One example here of from South America of where we've seen this reduction in notified dengue incidents following deployments was the city of 500,000 people in Brazil. This is in the state of Rio de Janeiro, a city called Niterói, where again the blue shading shows the Wolbachia release period, staged releases throughout the city. And after several years of real absence of dengue in this city, 2024, which as you will recall was the biggest dengue outbreak on record in the Americas, and Brazil, one of the worst affected countries, we can see here that it's not a perfect blocking intervention. It doesn't stop all transmission, but this, the paper that I've cited there that is under review at the moment, shows that what was seen in 2024 was vastly lower than what would have been expected in Niterói in the absence of the Wolbachia intervention. We use the same approach with the notified dengue case data to evaluate impact in other sites, but this is within the limitations of the existing disease surveillance system. So I've shown two examples here, Port Vila on the left and South Tarawa and Kiribati on the right, where there's challenges in terms of not having a very long historical time series of dengue data to be able to compare the post-intervention period. And also there's sometimes challenges with understanding where dengue cases live rather than where the health facility is that they're reported from, which is complicates the evaluation of impact. So in summary, as I've explained, the Wolbachia-based methods for arboviral disease control are innovative but are being scaled up in multiple countries. There's two different modes of action. I've talked mostly about the replacement method with males and females being released. And the benefit here is that it only needs to be done once and is then self-sustaining. So it's highly cost-effective in large urban centres. I've showed that this method can be deployed at scale. There's been large-scale deployments across populations of more than 1 million people in Indonesia, in Colombia and Brazil. And on the basis of the evidence that we generated and submitted to World Health Organization's Vector Control Advisory Group, there's a policy recommendation being developed. But there are challenges in taking this forward and having it, fulfill potential, I guess, in terms of addressing that increasing dengue problem that we're seeing worldwide. Some of that's technical. How do you industrialize the production and supply chain of these mosquitoes? But some of it's operational around how does this transition to government-led implementation for scaling up, and what regulatory and policy pathways are needed for this intervention, which doesn't fit into the existing regulatory frameworks for insecticides, etc. And financing, affordability and financing. Yes, it's highly cost effective, but that's over a long time horizon, and there's still capital expenditure and upfront costs required to produce mosquitoes and deploy. And just to highlight in my final slide that this intervention should be seen as complementary to all the existing approaches that we've heard about. So mosquito surveillance and control, vaccines that are starting to be used more widely, as well as the other disease surveillance and outbreak preparedness, and of course, careful case management, diagnostics and therapeutics. And all of that relies on, having cross-sectoral partnerships, advocacy and financing for dengue as well. Thank you very much. Happy to take any questions at the end of the session.
Thank you, Professor Anders. Thank you for your excellent presentation. So the next speaker is the Professor Zhang. Professor Tran is the Associate Professor and a Distinguished Public Health Researcher and Vice Director for the Grant and Innovation Center at the University of Medicine and Pharmacy at Ho Chi Minh City, Vietnam. He leads the Department of Environment Health within the Faculty of Public Health, where he has been a lecturer since 2011. Dr. Zhang specialized in environment epidemiology, biostatistics, and health risks assessment, with a focus on the interplay between climate change, air pollution, and human health. His extensive research portfolio, including leading projects funded by prestigious organizations such as the USAID, National Health and Medical Research Council, to explore the health impact of environment factors in Vietnam and beyond. Today, he will present a case study on the software for dengue outbreak monitoring and forecasting in Vietnam, and drawing from his deep experience in the Western Pacific region. Let's welcome Professor Zhang.
Hi, hello, good morning. Thank you, Professor Qiyong, for your nice introductions. And dear esteemed guests and colleagues, I'm Trang Ngoc, and I'm currently associate professor in University of Medicine and Pharmacy at Ho Chi Minh City, Vietnam. And today I'm going to share with you my project about the software for monitoring and early warnings of dengue outbreak in a southern province of Vietnam, where dengue fever is still a significant public health issue. And in the next 15 minutes, I'm going to cover three parts. The first, very brief about the importances of the early detection and monitoring. And then I go directly to the software overview, show some functionalities of the software. And finally, we'll talk about the predictive capacities for the early warning of our software and model. Let's to set the context for presentation. Let's look a broader view. On the slide is a recent systematic review by our group about climate change and human health in Vietnam. And as you may know, that Vietnam is among the top 10 countries that most affected by climate change. And climate change significantly exacerbate the many health issues, including the dengue fever. And our review have found that dengue is one of the most sensitive disease to climate variable. For example, our study revealed that with 1 degree Celsius increase, will increase the number of cases by 10%, with a far more than other infectious disease, with only ranging from 0.4% to 2.5%. And in Vietnam, for dengue fever prevention and intervention, is still quite reactive strategies. For example, if you look at the table on the right, the picture on the right, showing that the dengue monitoring case and figure drawing by hand of the health officer at the commune health level. So it's a little bit quite low tech and quite reactive intervention. Reactive meanings we have to wait until the case happen, then the intervention will come after. For example, we do spraying the mosquito, or we can do some public health campaign, but only it can happen when the case identified. On another hand, proactive can activate the intervention based on the risks of the disease and even before the case happen. That's why we really need to change approach from reactive to the proactive intervention. And in order to do so, we develop a proactive software. So this figure shows our conceptual research framework. We develop a software with multi-level and multi-variable. For example, the first group of variable we consider is the climate factor. For example, the temperature, the humidity, the precipitation. And one interesting thing is we in this software we use so-called the good Tran search volume for the warnings. With the assumption, for example, in one specific place at the same time, if many people search the same keyword, for example, the fever or the dengue, meaning maybe that area have some problem with the outbreak based on the behavior on the internet space, can use that information for the prediction of the outbreak. And our previous study show that this data, the good Tran search volume, is quite effective for the dengue fever prediction. Of course, we also consider other kind of factor, for example, the social demographic factors like the population size, the community infrastructure, the migration and travel. We also consider the vector control, for example, the brutal index, the household index, and so on and so forth. And of course, we also use surveillance case, for example, the case identified from hospital or the community. We put on these factors into our software that can predict almost real time the risks for the outbreak, and then we activate the proactive intervention right after we identify the hotspot. That's our research framework. Okay, and why proactive and early detection and monitoring important? Because timely response can save life. You know, when we early detect the outbreak, we can it critical for family intervention, and we can activate right away the measure like the vector control measure or the public health campaign. And many study already rule that monitoring and early detection can reduction in cases and also can help to resources allocation to allow the health authority to allocate resources more efficiently, ensure that affected area receive the necessary support, such as the medical supply and healthcare personnel before an outbreak begins. That is the meanings and the benefits of the early warning and monitoring. And for our software, there are 5 main key functions. First, you look at here. Sorry, because the software in Vietnamese, so I show the picture in Vietnamese, but I try to explain in English. This picture is the main interface of the software, where you can real time see here the number of cases automatically created, and then this part of the main interface is the search volume Google index for some key important keyword that we identify through our research. For example, the dengue fever, the mosquito, and so on and so forth. And we can real time to see how the search volume this week happened about these keyword. And then, of course, we can see the number of case that already investigated, not yet investigated, or the mortality case. And the heart of our software, which is early warnings interface on the risk score. So basically, we use 18 variables to build the predictive map. And you see each variable will assign a score based on their value. And then we sum up the score to total 100. And then we divide it. There are 3 levels. If the score more than 70, meaning the high risk area. And if the risk score from 50 to 70 is the lower risk area or medium risk area, and below 50 is a low risk area. And then we can see here the total 82 commune of the Bà Rịa Vũng Tàu province can assign the risk score. And then we also have the function about the patient monitoring. You know, when we input on the information of the patient, then we can really see the patient on the map. Before, you know, our system usually collect information by the paper. So we really don't see how the patient on the map. But with the software, we can see, and then we can, you know, track the patient based on the information we want. For example, by the information, by the age, by the gender, or by the area, by any information we want. We have the filtering function here. And then the second function is the outbreak scanning automatically. based on some definition about the epidemiology association, we can define and scanning the outbreak. For example, within the 200 meter radius, if the second case, within 14 days compared to the first case, then the software automatically identify that the hotspot for the outbreak. And then we need to come to the place and do some very, measure to prevent the outbreak spread. That is the very good function, I believe. And then we have the vector surveillance function, of course. So we can the data of the vector, like protein index or household index, the larva index, and so on and so forth, can be input in the software and it can show on the map. Therefore, we can identify the hotspot of the vector. And the function about statistical reporting, the software can have the health authorities can customize the report. For example, they can create the patient list, or they can report the risk score, or they can just simple report the figure of the number of cases by week, by month, or even by year automatically, which is quite helpful. And finally, the HUD, as I mentioned, of the software is the predictive outbreak mapping. You can see here. And this mapping based on the 18 variable, 18 factor. And for example, it have many kind of factor. For example, the climate variable, the immunity of the community, and the good go trend, and the transportation, the characteristics of that area, population density, and so on and so forth. We all input into the model, and we assign the score for each variable, and we sum up to the 100, and we divide the cutoff for the definition of the risk area, or medium risk or low risk. And here I'm showing you the predictive capacities of our model. Of course, here I only show you some important and significant variable. It's not all the variable, but for example, here you can see the model can predict in advance from 1 to 16 weeks in advance. For example, for the good go trend, we can see here the rapid risk is 1.111, meaning when the good go trend search volume increase, and then 1 week later, the number of cases can increase by 11%, something like that. And for the sea surface temperature, it can predict in advance 16 weeks with the rapid risk quite high and significant. So this is more evidence. We show the figure, the association coefficient between the real case and the predicted case with align very much. The coefficient more than 0.8. And here maybe more clearly, the black line, the real case, and the red line is a predicted case. So very much fit among the time span 10,000, 10 to 2020. And how about the accuracies of our model across the time span? So we have quite a good model. For example, here, the accuracy of the model in 2 weeks in advance, very high. The accuracy more than 96%. However, 2 weeks or 8 weeks or 16 weeks, the accuracy is quite good. However, the sensitivities vary. It depends on location. it varies from 0.5 to 0.93. Mean reflect the differences in the local climate or the vector dynamic of that area. So meaning in the future, we need to also improve the model to increase the sensitivities of our model. So in conclusion, today I show you a web-based dengue fever prediction software. It can predict from 1 to 16 weeks in advance and demonstrate a high accuracy, 0.9 to 0.99, and a very high specificity as well. However, the sensitivity vary by region and need to improve in the future. And this software is a practical tool for the local health management in the Bà Rịa Vũng Tàu province, and with potential for broader adoption in other areas. So here you can see how technology can bridge the gap between the climate and health. And I believe together with technology, we can make climate data into actionable solution. With that, I want to conclude my presentation, and thank you very much, and looking forward to your question. Thank you.
Thank you, Professor Tang. Now I would like to invite all of our speakers to show up, and we could have a Q&A session according to the question raised up by our audience. So yes, and also Professor Liu.
Hello?
Hi.
Yes.
Yeah. Hi. Yeah, the first question is for Professor Liu. One of our audience asked that which weather parameter combination can be very optimal for mosquitoes breeding?
Yeah, thank you very much. And this is a very good question. And based on our research and knowledge, I find the temperature precipitation are very important. We can make use of this to predict their trends, the population trends, and also based on this, we can give early warning. For example, as in China, dengue is not endemic diseases. It's caused by the imported cases for the localized secretion of the virus. So we can add one of these the imported case data then to predict the dengue risk. Thank you very much.
Thank you, Professor Liu. And the second question is for Professor Anders. One of the audience want to know that how can the Wolbachia-based control method be sustained financially in each nation? It's a very interesting question.
Yeah, thank you. And I hope you can hear me okay. Yeah, this is a challenge, as we know, the public health budgets are limited in many of the countries where dengue is a big problem, and especially the vector control budgets have been estimated at, maybe $1 per person per year, or a lot less in some places. So I think it will not be possible within the existing vector control budgets within ministries of health to redirect those budgets to Wolbachia, even if countries really wanted to do so. It needs financing through other mechanisms, either within Ministry of Health or through engagement of ministries of finance, I think, because even though this typically thought of as a vector control intervention, it's in a way much more like vaccination, in the sense that you need to have that upfront investment in production and distribution and deployment, and then you have the long-term benefits in terms of health and economic benefits and not having to sustain. So I think it needs a a rethink of the financing mechanisms, more like capital expenditure and infrastructure investment rather than a vector control budget mindset to be able to do this.
Thank you, Professor Anders. And the third question is for Professor Zhang. So, which are the primary provider for the data that is input for your software you mentioned about in the case study? And how open are the government agencies to share their information?
Yes, thank you, Professor Chi. So for the provider of the data, there are many stakeholders involved in provide the data. First, the hospital, of course. On the hospital, we input the case into the software. And then for other variable like climate variable, it real-time extract from other service from the weather station. But we have some function that connect to the station, the weather station, and automatically extract real-time the data to input in the software. And some variable we need the qualitative of the expert evaluate to scoring or to score the variable, something like that. Yeah. So many stakeholder involved to provide the data for the software. And that also, I think, the key point here is how we can involve the stakeholder we want and collaborate with each other is very important for a successful software for intervention. Yeah.
Yeah, thank you very much. Due to the time limitation, I'll have a last question for three of our speakers. So, how can communities and policymakers work together to reduce the impact of climate change on vector-borne disease? Maybe we can take, you can take your turns.
Okay, thank you very much. I think this is very important. First, we really need the innovative input for policymakers to make a right decision. Yeah. And for the policymakers, they also need the input from different disciplinary research, and also for the multi-sectoral collaboration. And first, I think for the researchers, for the scientific or academic purpose, and if we got very good innovative modeling, and also the discoveries, and first we need to interpret our findings for the more popular ways for the public and policymakers to understand. Then they may make use of it for policymaking. Yeah, and so for this purpose, I think we need some promotions for our research and the research funding. Yeah, thank you very much.
Thank you, Professor Anders.
Okay, I guess I would say emphasize again the need for a really integrated approach across all of the existing tools and the innovative tools, because it's such a big public health problem. We need all of the tools in the toolbox, but also it's not going to be a one-size-fits-all approach, both in terms of how different communities are affected by the impacts of climate change on dengue and other health problems, and also which interventions are going to be most effective and feasible and affordable in different settings. So we need to engage with communities, the public health promotion, everything they can do in their community-based approach to reduce mosquito breeding sites, as well as involve them in understanding the innovative tools and where they're going to be effective. There were a couple of questions in the chat about climate change impact on Wolbachia. There are potential limitations in very hot heat wave settings where Wolbachia might not be successful because it can drop out in the very extreme temperatures. So understanding which interventions, where is vaccination make sense, where does Wolbachia make sense alongside the conventional approaches is going to be a key factor. Thank you.
Thank you very much. Professor Tang?
Yeah, thank you. From my side, I think to enhance the collaboration, there are three main things. First, we need to have some shared goals and communication. Collaboration start with a common objective. Otherwise, we couldn't do it together. And then regular meeting or workshop or legal platform will make people stay alive. And the second important things, I think we need to have like the data integration and sharing platform. Like my software, it will not be success if we don't have agreement on sharing the data onto the same platform. That can be helpful for many stakeholders. It can be used for a hospital. It can be used for the community health member, or even can be used for the CDC or for the government. So we need to have agreement on sharing this data platform. And finally is the feedback loop and adaptation. So the stakeholder must evaluate the outcome of the project and adjust, and then keep iterative process to ensure the solution stays relevant. That's three main points I'm thinking about. Yeah, thank you.
Thank you. Thank you for all of you for your insightful presentation and knowledge sharing. So last but not least, I would like to ask all the participants to join the course WhatsApp group or WeChat for updates and information for the course planning team and for the better collaboration in the future. So for the post-session, we provide a post-session survey. So you can scan with your phone camera or link in the chat. And last but not least, thank you for your all attendances, and please keep on attend the following 4 sessions in the following weeks. Thank you very much. Thank you for all your participation today.